The best of RSNA is coming to you in these two exciting new Spotlight courses. Explore head to toe emergency imaging in the virtual Spotlight course, Best of RSNA Insights, Innovations, and Interactive Learning in Emergency Radiology, taking place April 3rd and 10th. Or join top presenters from RSNA in Istanbul, Turkey for the in person Spotlight course, Expert Insights on Emergency and Abdominopelvic Imaging, on June 28th and 29th. Learn more about both courses and register at rsna.org/spotlight.
Hi, welcome to the RSNA Radiographics podcast. My name is Richa Patel. I'm Clinical Assistant Professor of Body Imaging at Stanford University and the Associate Program Director of the Stanford Body Imaging Fellowship. I'm also first author on a recently published radiographics paper titled Improving Diagnosis of Acute Cholecystitis with Ultrasound, New Paradigms. I want to first start off by just saying that there is no one sonographic finding that we yet know of that cinches the diagnosis of acute cholecystitis. I think we all wish it were that easy, but these cases are often more nuanced than we were perhaps led to believe. Today, we will be discussing some unique features on ultrasound that can be utilized to better assess acute calculus cholecystitis. And moving forward, I'm just going to refer to this as acute cholecystitis, but we're really focusing on the calculus type. We've always learned acute cholecystitis to be a very bread and butter diagnosis in radiology, but accurately diagnosing it is much tougher than it seems. The classic features of sonographic Murphy sign and the presence of gallstones are perhaps not enough to reach that diagnosis. So in our paper, we wanted to discuss more predictive features that radiologists can be attuned to in better diagnosing cholecystitis by ultrasound. Before we actually dive into those features, it's really important to understand the pathophysiology of acute cholecystitis so you understand what you are actually seeing on imaging. Now, acute calculus cholecystitis essentially entails obstruction by a gallstone that generates a ton of intraluminal pressure within the gallbladder. And that induces these mucosal phospholipases to generate these highly toxic lysolecithins. Now, these very, very toxic lysolecithins ultimately disrupt the mucus layer of the gallbladder wall, and that eventually allows bile to contact the epithelium and inflict damage. Gallbladder distension on top of that from this obstructing stone can impede mucosal blood flow, and that also potentially results in ischemia. The 2018 Tokyo guidelines are used to diagnose and grade acute cholecystitis, and they rely on physical exam with the clinical Murphy sign, right upper quadrant pain or mass. They require biochemical signs of systemic inflammation like elevated CRP, leukocytosis, fever, and they include imaging findings. However, there are very little clearly identified criteria of imaging acute cholecystitis. Ultrasound, CT, MRCP, and HIDA scans can be used to work up cholecystitis, but ultrasound is really the first-line imaging modality recommended by the Tokyo guidelines and the ACR appropriateness guidelines, as well as the 2020 World Society of Emergency Surgery. It's performed pretty expediently. It can be performed at the bedside. It doesn't require IV contrast or any ionizing radiation. So I want to touch on each of the sonographic features that we outline in our paper because each of them uniquely offers insight into the pathology that radiologists can see on imaging. I want to start off with the first 7 features, and these first 7 features are the new paradigm features that we think can help you make the diagnosis of acute cholecystitis. Feature number 1, gallbladder dilation. So the initial feature of calculus cholecystitis is marked by gallbladder outlet obstruction, as we talked about. A transverse diameter that is less than 2.2 centimeters essentially excludes cholecystitis in the absence of gallbladder rupture. If the gallbladder fundus bulges out against the abdominal wall, this is fundal tension, and this suggests high intraluminal pressures. You can assess this with a linear high-frequency probe and by exerting minimal downward pressure on the gallbladder itself. This was actually shown to be 74% sensitive, 96% specific for acute cholecystitis in patients with right upper quadrant pain. Now, there may be some pitfalls where even a distended gallbladder in certain patients isn't distended enough or doesn't, because of its anatomic positioning in that patient, contact the abdominal wall. And that's just because, again, of the patient anatomy. Another pitfall is when the gallbladder is decompressed from perforation or when the fundus is just deep to a rib, and that rib will certainly prevent the gallbladder fundus from actually deforming the abdominal wall. Feature number 2, gallbladder sludge. So, gallbladder sludge is inspissated material that does not shadow on ultrasound, and it's usually seen in patients who are sick to some degree. They're patients who are often prolonged fasting states. So, they're in the ICU, they're post op, they're on TPN. And what happens with fasting is the gallbladder doesn't empty, so it starts creating this sludge. Other than pregnancy, sludge in outpatients is exceedingly low. So, in patients with right upper quadrant pain with sludge, you should certainly suspect gallbladder dysfunction. Feature number 3, gallstones. Now, gallstones are becoming increasingly more prevalent, now affecting 10 to 15% of adults in Western populations. They're often associated with risk factors like obesity, certain medications, cirrhosis, Crohn's disease, a metabolic syndrome, diabetes. Gallstones alone do not predict cholecystitis. Actually, only less than 10% of patients with gallstones actually get cholecystitis. However, patients with gallstones do get biliary colic by transiently mimicking cholecystitis symptoms. That being said, the gallstones impacting the gallbladder neck or cystic duct are the most concerning. Feature number 4, wall hyperemia. So typically, gallbladder inflammation results in increased blood flow. So, on color or power Doppler ultrasound images, we might perceive this as hyperemia of the gallbladder wall. But we can actually quantify this increased blood flow. So, a hepatic artery velocity should be sampled just as it travels parallel to the main portal vein. If it is greater than or equal to 100 centimeters per second, it is statistically significantly correlating for acute cholecystitis, more accurately than either gallstones or sonographic Murphy sign. Now, the issue is that the hepatic artery perfuses the gallbladder and the liver, so hepatic inflammation could also elevate the hepatic artery velocity. So, to combat that, the cystic artery velocity can be helpful. The cystic artery only perfuses the gallbladder and is therefore a more sensitive indicator of gallbladder inflammation alone, with less potential influence from primary liver pathology. A cystic artery velocity greater than or equal to 40 centimeters per second is 72% sensitive, 84% accurate, and has a positive predictive value of 92% for acute cholecystitis in patients with right upper quadrant pain. Gallbladders that have borderline elevated velocity should still be scrutinized for other sonographic features of acute cholecystitis. So keep that in mind. The 100 cutoff for a hepatic artery velocity and the 40 centimeter cutoff for a cystic artery velocity is not a hard and fast rule. That's something to always keep in mind when you're reading these scans. Now, also take note that this might not be as predictive in patients with gangrenous cholecystitis. So, in gangrenous cholecystitis, you may have altered perfusion of the gallbladder, and therefore, these cutoffs and these thresholds, this velocity assessment might not actually be as predictive. Feature number 5, echogenic pericholecystic fat. So, there is transmural spread of inflammation beyond the gallbladder wall to the surrounding fat in the omentum and the triangle of Callot. On ultrasound, this appears as hyperechoic fat, and the CT-MR equivalent of this is pericholecystic stranding. Now, be sure that you are not always assessing fat immediately deep to the gallbladder on your images. That is definitely a fake out and can yield a false positive because that fat is inherently going to be echogenic. And the reason is because there's increase through transmission of your ultrasound beam through biliary contents of the gallbladder. So that fat deep to the gallbladder is always going to appear a little bit brighter. That is not echogenic fat from transmural spread of inflammation. That is simply echogenic fat because of increase through transmission. If you do see echogenic fat around the gallbladder, though, that does increase the likelihood of gangrenous cholecystitis. Feature number 6, loss of mucosal sonoreflectivity. So the ultimate downstream effect of acute cholecystitis is gangrenous change, and that's seen in up to 39% of patients, especially those who are elderly or those who have diabetes. Now, ultimately, this can cause higher mortality, rates of sepsis, a greater need for open cholecystectomy, and a longer hospitalization. Normally, your gallbladder mucosa is echogenic, but when inflamed and when there's mucosal breakdown, you lose that sonoreflectivity, and that may suggest early mucosal ischemia and gangrenous cholecystitis. This is especially apparent when using a high-frequency transducer. Again, ultimately, this can progress to gangrenous changes and ultimately discontinuity of the wall and perforation. So the CT and MR equivalent of loss of mucosal sonoreflectivity is just wall hypoenhancement that you may see. Now, if the mucosa actually starts peeling off, that's that classic sloughing mucosa that we learned about, and that is a very specific sign for gangrenous cholecystitis. The last new paradigm feature, feature number 7, mucosal discontinuity and perforation. Once the gallbladder has perforated, you might see an abscess. Patients might have bile peritonitis, they might be septic. Be very, very much hypervigilant in really assessing the wall of the gallbladder on your scans. Perforation can occur anywhere along the gallbladder wall, including the bare area of the gallbladder, which is the portion of the wall that immediately abuts the liver, or the gallbladder fundus, which is the area furthest from the blood supply, so perhaps the most susceptible to ischemia. Now, when this perforation happens, the gallbladder essentially deflates. So, if you're suspecting perforation and you do not see gallbladder distension, that does not exclude perforated cholecystitis. You can even use CT or contrast enhanced ultrasound to help evaluate for areas of mucosal discontinuity and assess the entirety of the gallbladder perforation or any other associated collections. The last 3 features I want to talk about are pre-existing older features of acute cholecystitis that we also discussed in our paper, and I think they are still very important to understand. The first old feature of acute cholecystitis is the sonographic Murphy sign. So the actual Murphy sign is when the examiner on actual true physical exam would hook their fingers under the right costal margin of their patient, ask the patient to take a breath in, and that would cause the gallbladder to descend. And then the gallbladder would contact those fingers, would contact that area of palpation. Now, this can be very painful if the gallbladder is inflamed, so the patient would suddenly stop breathing, and that was a positive Murphy sign. Similarly, the sonographic Murphy sign is when the patient has maximal pain when the transducer or the probe immediately overlies the gallbladder. Again, gallstones and sonographic Murphy together no longer have the accuracy of diagnosing cholecystitis that they once did in the early 1980s. Only 1/3 of patients with acute cholecystitis actually have a positive sonographic Murphy. Also, patients who have analgesia, who are older, who are diabetic, or who have gangrenous changes could have impaired pain perception, so may have cholecystitis without the positive sonographic Murphy. One more thing to keep in mind is that adjacent organs like the liver, the pancreas, the stomach, the duodenum, when they are inflamed, they might also yield a positive sonographic Murphy sign. So it's not necessarily the most specific marker of gallbladder inflammation alone in that situation. And remember, this is a very operator dependent sign. You are highly reliant on your operator to do a really, really accurate assessment to elicit pain or not. The second old paradigm feature of acute cholecystitis is gallbladder wall thickening. So we define wall thickness as greater than or equal to 4 millimeters. Make sure you measure the gallbladder wall right at its interface with the liver. It's really the area where the wall is most clearly seen. And remember that wall thickening of the gallbladder is not unique to cholecystitis. In fact, many patients with cholecystitis don't have gallbladder wall thickening. And instead, the thicker the gallbladder wall, especially gallbladder walls with a striated appearance where edema is essentially separating the wall interstices, could actually occur from other non-cholecystitis pathologies, mainly low albumin states, hepatitis, pancreatitis, congestive heart failure, etc. The third old paradigm of acute cholecystitis is pericholecystic fluid. So this is the last finding of pericholecystic fluid, is often a later finding of acute cholecystitis. It's sympathetic fluid from gallbladder inflammation. It may be absent early in the course of cholecystitis. The problem with this finding is twofold. One, gallbladder wall edema and pericholecystic fluid can be easily confused for one another. Two, reactive ascites from other causes can also collect around the gallbladder and result in a false positive of pericholecystic fluid. So the bare area of the gallbladder, that area that I referenced earlier when discussing perforation, remember that area where the gallbladder immediately abuts the liver, it does not have a peritoneal covering. So ascites should never really enter the space. So if you see fluid in this space between the gallbladder and the liver, it is some form of pathology, and you should most certainly worry about gallbladder perforation. Okay, so we went over these 10 features of acute cholecystitis, and my hope really is that you can use these to adjust your diagnostic acumen when interpreting these ultrasounds. You can confidently exclude cholecystitis in a non-distended gallbladder, less than 2.2 centimeters in width, and if it's otherwise normal. In acute cholecystitis before perforation, the gallbladder is dilated to some degree, so more than 4 centimeters in transverse dimension, more than 8 centimeters in longitudinal dimension. Make sure you look for additional findings such as tensile fundus sign, sludge, and impacted gallstone, elevated hepatic or cystic artery velocities to help you make this diagnosis. If you lose your mucosal sonoreflectivity, if you start seeing wall discontinuity or echogenic pericholecystic fat, This may suggest gangrenous changes or perforation. Thank you so much to RSNA, Radiographics, and the Radiographics team for giving me this opportunity to really highlight a very, very important topic. Special thanks to my co-authors, Doctors Lu Yao Shen, David Bingham, Justin Shi, and Aya Kamaya, all from Stanford University, for their tremendous work on what I believe is a really sentinel paper. Just a reminder to please rate, review, and subscribe to this podcast. Your support and engagement really helps expand our audience beyond just the Radiographics readership. And please be sure to give the paper a read on the Radiographics website, as well as other fantastic educational and highly clinically relevant articles that amazing radiologists from all around the world are publishing. Thank you so much for tuning in. Bye.